Our next presenter is Dr. Natasha Radhakrishnan.
Good afternoon to all. My topic is visual outcomes in pediatric non-infectious uveitis. Are biologics a game changer? Pediatric non-infectious uveitis is an uncommon vision-threatening condition, accounting for 5 to 10% of all the uveitis cases. Children, as you know, are asymptomatic in the early stages, and the disease follows a chronic recurrent course. Delayed diagnosis due to the silent nature of the inflammation and examination difficulties increases the risk of sight-threatening inflammation. So why this study? Corticosteroids and immunomodulators are standard therapy but often fail to achieve long-term control or the steroid-sparing effect. Biologic agents, especially adalimumab, have shown efficacy in refractory cases, and real-world data from India are limited, and this study evaluates the short-term visual outcomes in pediatric non-infectious uveitis, focusing on the impact of adalimumab therapy. Retrospective study conducted at a multidisciplinary pediatric rheumatology ophthalmology clinic in South India included children less than 16 years with confirmed non-infectious uveitis and more than 6 months follow-up, and we excluded the infectious uveitis incomplete records or shorter follow-ups. The final cohort had 82 children, 139 eyes that met the eligibility criteria. The data was extracted using a structured proforma, and the uveitis classified according to the Sun classification. The visual acuity was grouped in the beginning at baseline and at last follow-up as group 1 less than 0.3 logmar, group 2 0.3 to 1, and group 3 with more than 1 logmar. And primary outcome was change in the mean logmar BCVA and visual acuity distribution at last follow-up. The secondary outcomes were the ocular complications and new onset ocular hypertension with subgroup comparison between the biologic group and the conventional therapy group. The analysis was performed using the SPSS software, and continuous variables were summarized as mean plus minus standard deviation and categorical as frequencies and percentages. The Wilcoxon sign rank test and the chi-square test were used. The results, if you look at the demographics, 82 children with non-infectious uveitis, of which the mean age was 12 years with a slight female preponderance. Laterality was bilateral in 69.5 with a chronic course in 78%. JIA was the most common diagnosis, 45.1, followed by idiopathic uveitis. The anatomic type was anterior uveitis followed by panuveitis, and a total of 590 person-years of follow-up with an average of 54 months of follow-up was there in the study. The treatment profile, if you look, the methotrexate was the mainstay of systemic therapy. Combination therapy with the biologic agent was required in 36.6%, and the most frequently used biologic agent was adalimumab. Our rheumatologist has the protocol that we follow in our rheumatology treatment for these children is to start them off on methotrexate and systemic steroid, taper and stop the steroid over 6 months as early as possible, and continue on methotrexate alone. Usually subcutaneous methotrexate was given, and when the patient has either a recurrence or not control of inflammation in 3 months of methotrexate alone, they would be shifted to adalimumab along with the methotrexate. The ocular complications occurred in 58 eyes, with the most common being cataract and band-shaped keratopathy. Intraocular hypertension in 28 eyes, but was less frequent when we shifted to the biologic group compared to the non-biologic group. The visual acuity, the mean BCVA improved significantly from 0.34 at baseline to 0.26 at 6 months. Eyes with good baseline vision remained stable, while those with poor baseline vision showed limited recovery. Vision loss more than 3 ETDRS lines occurred only in 10 eyes, and they were all in the non-biologic group. So inference is that short-term visual outcomes were excellent, especially patients who present with good baseline visual acuity. Methotrexate with or without biologics remains the mainstay of therapy, and systemic immunomodulatory treatment improved visual outcome at 6 months. But if you compare the adalimumab based, those who got adalimumab and those who did not, the adalimumab subset showed better visual preservation and fewer onset of new complications compared to the conventional therapy. JIA remains the leading cause as in all literature. Cataract and BSK, the most common as in all literature. The mean BCVA improves from over 6 months with good treatment, and eyes with good baseline vision are the ones that largely remain stable, underscoring the importance of early detection and treatment. And when you look at the role of biologicals, the biologic use was higher in our cohort compared to other South Indian series. We had a 43% use of biologics compared to other South Indian series, that is only 7 to 10%, which reflects a shift towards early biological initiation. And children on biologics had better visual stability and fewer new onset complications. The Sycamore trial now shows that adalimumab plus methotrexate reduced uveitis relapse by 75%. The Adjuvite trial confirmed adalimumab's efficacy in reducing inflammatory flares, and real-world data is there from Europe and North America showing improved visual outcomes and reduced disease activity. However, our limitations are that it is a retrospective single-center study, and for future prospective multicentric studies, especially with cost effectiveness of the biologic therapy, are necessary in the Indian context. So in conclusion, biologic therapy with adalimumab added to methotrexate provided better inflammation control, fewer complications, and superior vision preservation, aligning with global evidence. And it highlights the importance of multidisciplinary management and timely initiation of biological therapy. Thank you.
Very good, Natasha, really. I have a question again. So you said adalimumab was used in how many children?
In 54%.
So was there a reason not to start these?
There are a lot of no. There are a lot of patients who cannot afford adalimumab.
Cost
so
was the issue.
Yes, cost was definitely there, and they were started on MMF and not on adalimumab. So we had a cohort that had only the non-biological agent and a cohort that has biologics.
So that's your main, reason not to, start these children on adalimumab.
Any difference of using biologicals in pediatric, like you said, less than 16 years of patient versus adults? There is any difference in the efficacy or side effects? Or
the one thing that is absolutely contraindicated is infection. So they always do like a TB test before starting adalimumab. But adalimumab generally is not that effective in adults, and that is not the first line choice for adult uveitis, but in children it is the first line from various studies. In adults, they tend to go more with either tofacitinib or the other immunomodulators.
Any specific reason for that? Why adults, don't respond, or children respond more?
I think it is because adalimumab is better tolerated and has less bone marrow suppression than the other group.
So, let's say compared to MMF or any other drugs that you routinely used, what are the side effects that you're going to look for in children with that you put them on adalimumab?
Basically, they follow up with an RFT and an LFT, and also look for any amount of infection. So usually when the patient has like a cold, that is rhinitis going into a pneumonia or something like that, we have to withhold the adalimumab for some time. Otherwise, generally, like we have a very long follow-up and they're very well tolerated. Because the children don't really develop any side effects on adalimumab.
So you educate the parents that if there is, if they find any signs of, let's say, URI or so, you stop it? Is that?
No. They are asked to continue, but they are asked to, if there are chest signs, they are asked to get in touch with the rheumatologist.
Thank you.
And you routinely get investigations in these pediatric patients for to rule out COX, and if the MON2 is positive or the finding, you give ATT course before starting biologicals?
No, we usually avoid the biologicals completely because it is too risky. You cannot do it like steroids. We can give ATT plus steroid, but with biologics, because of the bone marrow suppression that comes in, we cannot take that risk and give. Your B cell immunity becomes very reduced. So you cannot give biologics unless they have completed the course. After they have completed the course, they are considered as a normal child.